Hi, everyone. My name is Rida Hasan. I am an associate medical director and an assistant professor at University of Washington in Seattle, Washington. And I'll be talking to you about DAT testing in the diagnosis of autoimmune hemolytic anemias and present some of my research specifically related to elutions. Just a brief outline, there's three parts to this lecture. One is going to be a very brief overview of DAT testing. Then we'll talk about elution testing, which some people may or may not have heard of, and you may or may not have seen it as the results within lab testing when you're evaluating your patients for autoimmune hemolytic anemia. And then finally, I'll go into my research that looked at a retrospective study about the diagnostic value of doing elution testing for our patients. So the diagnosis of autoimmune hemolytic anemia is based on the evidence of clinical hemolysis and also having laboratory evidence that you have red cell autoantibodies. This is specifically for warm autoimmune hemolytic anemia. There are other causes of immune-mediated hemolytic anemia that I'll cover in my lecture, so I'll be talking about it very broadly. So, in general, you have a patient with anemia, you're concerned for hemolysis. The next thing the physician will do is they'll order a DAT. If the DAT is positive, that leads you down one pathway. However, if the DAT is negative, then you're thinking this is probably not immune mediated, maybe mechanical hemolysis, some kind of membrane disorder, some hemoglobinopathy, and there's a lot of other differentials you can also think of. If the DAT is positive, though, now you're thinking this is immune-mediated hemolytic anemia, and that just emphasizes that you think an antibody is the one that's causing the hemolysis. So autoimmune hemolytic anemia, cold agglutinin disease, fall within this umbrella of immune hemolytic anemias, but there are a few others that are out there. So a DAT test is also called a Coombs test colloquially. And what exactly is a Coombs test? So it's a test that's done in the blood bank where we determine this is a red blood cell, and yes, it has presence of antibodies that are bound to the red blood cell. It often has very similar requirements to other samples in the blood bank, such as a type and screen. So it might be that at your institution, you need to have two people verification. Um, when you draw a Coombs test, just because it is a blood bank test, but it's not actually used to make any specific transfusion decisions. The type and screen is still going to be the gold screen for that. When we think about antibodies, since we are talking about immune-mediated hemolytic anemia, such as autoimmune hemolytic anemia, we have to understand what exactly is the structure of the antibody and what is the outcome when an antibody binds to a red cell. So you have an antigen binding site, which is pretty clear. So it's going to bind to a very specific epitope on the red cells. And then you have your FC receptors. And these are important because that's going to determine what is your antibody once it's bound to the red cell, what is the outcome in your patient? What does it do? So it can do two things. It can either activate complement or it can bind to the FC receptor binding site. So what happens is that the antibody binds to your red cell if it activates either the complement binding site or the FC receptor binding site. And we've always thought that complement binding sites is what's going to trigger intravascular hemolysis. So this is where you'll see schistocytes, you'll see an elevated LDH, low haptoglobin, a really sick patient. And then on the other side, the FC receptor binding site is going to cause extravascular hemolysis. So this is where you're going to see spirocytes, you're going to see an elevated bilirubin, and more signs of extravascular. The DAT is great at testing two different kinds of antibodies. One is the IgM, which actually it doesn't detect directly. It detects through the presence of complement because IgM is a very strong activator of complement. But as you saw in my previous slide, IgGs, actually all antibodies, do have some degree of complement activation. It just depends on that specific antibody. The DAT is also great for IgGs. So if there's IgGs bound to your red cells, it should turn positive. When an IgG binds to your red cell, we really think about, again, those spirocytes, the spleen being involved and then causing extravascular hemolysis. Some degree of it will also, when C3b binds to it, will go through the liver, where you'll have your elevated bilirubin, and then a very small percentage will have C5 bind to it, where you have a MAC complex and intravascular hemolysis. But most of your pathway is going to fall within the first two for what happens when an IgG binds to it. And just understanding a little bit more about the intravascular hemolysis pathway, this just shows that you can have complement activation. So it's going to activate the classical pathway where you're going to have opsonization of your red cell and you're going to have phagocytosis, extravascular hemolysis, and also MAC complex formation that's going to cause the intravascular hemolysis with classic free hemoglobin and the schistocytes that we really think about in our patient population. And IgM does exactly the same thing. So it can activate exactly the same pathway, but its extravascular hemolysis is really not as pronounced. It's mostly going to be intravascular, is what we're seeing in IgMs. I was always taught to differentiate the IgM versus IgG, thinking IgM is only intravascular and IgG is only extravascular. And then throughout training and clinical practice, I've realized that it's not divided. They're actually a continuum. So IgM can activate some degree of extravascular hemolysis. So you might have a cold with a little bit of IgG reactivity. And same thing the other way around. We often see IgGs that actually have complement activation. So we'll see a patient that has autoimmune hemolytic anemia who has 3 plus IgG and 2 plus complement. And that's actually a pretty common finding that we see. And it's because IgG can absolutely activate complement and cause a little bit of intravascular hemolysis. Okay. So how is a DAT performed? Now, going into the lab where I spend most of my time, um, we're in charge of the blood bank of the DAT testing. And essentially, the question we want to ask is there agglutination? That means the antibody is present, and or is there no agglutination, meaning the antibody is absent? So if my red cell is coated with antibodies, if I add different types of anti-human antiglobulin reagents to it, I'm going to see agglutination, as you can see in the top, because that's going to cause those red cells to stick together, and I'm going to be able to see it visually. If there's no antibodies, I can add as much reagent as I want, but there's nothing for that antiglobulin reagent to bind to. So the antiglobulin reagent is essentially an antibody to an antibody. So if there's no antibodies present for it to bind to, then I will not see any agglutination. And this is another visual of how the Coombs reagent can cause either a positive DAT or negative DAT. And when we talk about agglutination, we do grade it. So it's a scale of 0 to 4, and this is often what you're seeing in the lab results. So you're seeing either weak, 1 plus, here on the 0 to 4 scale, 2 plus, 3 plus, 4 plus. There's 3 types of anti-human globulin reagents we use. So the first thing we use is a polyspecific reagent. And that is going to be what most labs start with, and it binds to both IgG and complement. So the good thing is that if your polyspecific is negative, then you're done. You don't have to go on to do the other reagents because it's basically told you there's no IgG or complement bound to it. But however, if it's positive, then you go to do the monospecific reagent. So that's going to be your IgG and then your C3. In our lab, we do C3b, C3d. Every lab is a little bit different, but most labs will do either one of these. And again, thinking that IgG is going to be warm reactive antibodies that are associated with extravascular hemolysis, and then your complement is going to be cold reacting antibodies like IgMs that are associated with intravascular, but also keeping in mind that it is a continuum. So how do you interpret the results? So if my polyspecific is positive and my IgG is positive and complement is negative, I'm going to think, okay, this is an IgG antibody, probably like autoimmune hemolytic anemia, warm autoimmune hemolytic anemia specifically. If my poly is positive, my IgG is negative, and my complement is positive, then I'm thinking, oh, this is cold, like cold agglutinin disease. Now, in this scenario, my poly is positive, my IgG is positive, and my complement is positive. And some people can have mixed type autoimmune hemolytic anemia where they have warm and cold antibodies, but that's actually not the most common reason we see this. The most common reason we see this is usually because of an IgG that can activate complement pretty well. So about 1/3 of warm autoimmune hemolytic anemias will actually have a positive complement. And then the other scenario would be that your polyspecific is negative. NT means not tested, so we don't do a monospecific IgG or complement, and then we say, okay, there's no antibody probably bound for negative DAT. So now that your DAT is positive, your patient has hemolysis, your DAT is positive, do you have enough to diagnose autoimmune hemolytic anemia? And a lot of papers that are out there in terms of like how I diagnose autoimmune hemolytic anemia and going into the history of that are very thorough. But I think um, they do depend a lot on the DAT positivity. So this is one out of the New England Journal of Medicine, and it says if your DAT is negative, probably not autoimmune hemolytic anemia, versus if it's positive, then you do the monospecific anti-sera. So that's the IgG and complement that I discussed. And you can see that, specifically to what I said, very similar. They're thinking either warm or cold based on the pattern. However, there is a whole differential that you have depending on your DAT being positive. So if your DAT is positive and it's IgM, you're thinking complement. Again, IgGs can be weakly positive in these situations. So now you're thinking really cold agglutinin disease. If it's IgG, now you have a whole differential of autoantibodies. We're thinking warm autoimmune hemolytic anemia, but you can also have alloantibodies that can be positive for IgG. So we don't think about this as much on the autoimmune side, but these can cause pretty significant hemolysis. So having a hemolytic transfusion reaction, or specifically due to ABO antibodies or against other alloantigens on the red cells. You can also have things like hemolytic disease of the fetus and newborn, passenger lymphocyte syndrome. And then the third category is drug-induced hemolytic anemias can also have a positive DAT, and there's two different broad spectrums of it. I'll talk briefly about this. I'm going to categorize it as its own thing for now because it's just so variable what the presentation can be. But in general, what I'm trying to get to is that once you have a positive DAT, it doesn't automatically commit your patient to autoimmune hemolytic anemia. There is still even if the even if it's just IgM, it could be cold, absolutely. But if it's IgG, the differential is pretty broad. Still, warm is just one of the many kinds of antibodies that your patients could have bound to it. And there are other antibodies and there are other disease states that you have to think about in the setting of just a positive DAT. So there is a next step that the blood bank does. It's an elution study. And you may or may not have heard of this. An elution study is used to determine what is the specificity of the antibody that's bound to the red cells. So this is important because, like the prior chart, if it's an autoantibody, now I'm thinking warm autoimmune hemolytic anemia. If it's an alloantibody, now I'm thinking, oh, it's not to the patient's own red cells. Maybe they were transfused. Maybe it's a hemolytic reaction, or maybe they got transplant or they were pregnant. They were exposed to some other blood, and the antibody is actually to that, not to their own. And then for alloantibodies, the treatment is going to be a little bit different because when we transfuse these patients, we actually do avoid that antigen going forward. So if someone has like an anti-big E on that elution and they had a delayed hemolytic reaction from it, I would give them big E negative units going forward. Versus a patient who has an autoantibody, there's really nothing we can give besides normal red blood cells for those patients. So that's where the eluate comes in. And the eluate, the process is also called an elution, and the end result is called an eluate. So I'll use those terms interchangeably. The elution is a step that we take that where after we know the patient has a positive DAT, we remove the IgG that's bound to the patient's red cells. And once that IgG is unbound, now I can see what is it binding to because I don't really know what it's binding to in my patient's red cells. But if I have a couple of reagent red cells and I know what antigens they have and what's expressed on them because they are reagent cells, I have more control about determining what's the specificity for what they're binding to. So that's what we do. We remove the antibody and then we test it against these reagent cells. And this is, I just want to make this point because clinicians get confused about this all the time, is that the DAT is performed on the patient's red blood cells, and the eluate or elution is performed on reagent red blood cells. And in this specific scenario, the antibody of interest that we're worried about is removed from the patient's red blood cells and can tested against various reagent red blood cells to determine specificity. So how do you interpret an elution result? Um, If we see that the antibody we eluted is reacting against every cell, every reagent cell, then we think, oh, this is a panagglutinin, meaning that it's reacting to a high incidence antigen that almost everyone expresses. So this is pretty consistent with a warm autoimmune hemolytic anemia. What if that antibody we removed is only binding to red blood cells that express the big E antigen and not any of the red cells that don't express this big E antigen? Then we say it's an anti-big E that's eluded. So now maybe the patient was actually exposed to a red blood cell that was big E positive, and now this is a hemolytic transfusion reaction that we're thinking about. And then the third thing, which can unfortunately happen pretty frequently, is that when we elute off the antibody, it doesn't react to any of our reagent red blood cells. And now we say no antibody eluted. Some labs will say non-reactive. And this is, I think, is creates even more confusion because now you have a positive TAT but a negative elution study. When we think about how an elution can help us, when we're thinking about our IgGs, it really is very helpful because specifically when we're thinking about IgGs, it can help us differentiate an auto antibody versus an allo antibody and some of these other things that could be going on with like HDFN or passenger lymphocyte, which are actually other forms of allo antibodies, other disease states. And then it doesn't really help us with these. So it doesn't really help us with cold agglutinin disease, and it doesn't really help us with drug-induced hemolytic anemia unless we do very specialized testing. And I just want to take a minute to get into this. So cold agglutinin disease, the reason the elution doesn't work on that is because the way the elution is made, it's really just optimized for IgGs. There are solutions for IgMs that are available, but they're extremely difficult, very technical to carry out, and a lot of labs don't do them. There is potential send-out testing that you can do, but most places don't do them. And there are other studies that can help you if you're thinking your patient has cold agglutinin disease. So there's thermal amplitude, you can do titers. You can also do a treatment to determine if it's an IgG or an IgM bound to your patient's red cell. Those are studies that are available. And for drug-induced hemolytic anemia, the reason the elution doesn't work is actually pretty straightforward. So in drug-induced hemolytic anemia, the antibody is against um, the antigen that's created when your red cell is bound to the drug. So it's not specifically to your red cell itself, it's specifically to the red cell with the drug bound to it. Um, the drugs are really small, so themselves they can't elicit an immune response, but once they're bound to a red blood cell, they can. So if we assume that the yellow is the drug or what we're going to call the hapten, once it's bound to a red cell, your body can make antibodies to it. And this could absolutely result in a positive DAT. When we do the elution and we remove those antibodies and then we try to react it to reagent red blood cells, what happens is that there's no drug present. So we're often going to get a negative elution. There are specialized labs that, if you have high clinical suspicion for drug-induced hemolytic anemia, they will actually um, do the elution with a solution of the drug. So for these, they might even ask you to send a sample of the drug with the patient's sample. And what they'll do is they'll create a solution, they'll incubate the reagent red cells with it, and that'll allow the drug to bind to your reagent red cells. And then when you do the elution, you can see that it only binds to the drug that was exposed. Only to the red cells that was exposed to that specific drug, and that can help you with your diagnosis. Again, this is very specialized testing that's only done in a few labs across the country. So let's go through what's going to happen clinically. So how do we put all this together in clinical context? Okay. So if you get a straight shot, your patient's going to have hemolysis. It's going to be very easy to rule out non-immune causes. And you're going to say, I'm suspecting this is immune mediated. I'll order a DAT. The DAT will be positive. And then my elute will be positive for panagglutinin. This will tell me, okay, my patient absolutely has warm autoimmune hemolytic anemia. This is the treatment. I need to start steroids. However, it's not always that easy. You're almost in the basket, but not quite. So what's more likely going to happen is that your patient has hemolysis. They don't really have other non-immune causes you're thinking of, so you still want to evaluate and rule out immune causes. So you send off a DAT. Um, and maybe the DAT in this scenario is 1 plus your IgG 0, C3 0. Um, you ask for an eluate, or maybe it wasn't done because the IgG is negative. So you're kind of left with this question mark where you're like, I just want to really get to the diagnosis, but I don't know what to make of this. So I just want to emphasize that putting it all together, this is something that happens very common with clinicians where they have a positive DAT and a negative elution, or they have a positive DAT, but then it doesn't really, making the diagnosis can be a little bit difficult despite the presence of hemolysis because you're still not sure, is it immune or is it non-immune mediated? What I do want to point out, though, is that we know for sure that a positive DAT does not mean that your patient has a hemolytic anemia. So just because the DAT is positive does not mean that you have made this diagnosis. And the reason is because false positive DATs, unfortunately, are very common. In the healthy donor population, not as common, 0.1%, and they can be IgG complement, so there's not a specific pattern that we see. However, in hospitalized patients, upward to 15% of them can have a positive DAT, and these patients do not have hemolysis. What we think is happening is that maybe they have specific disease states where they're just more at risk for having antibodies bound to their red cells. They also maybe have elevated serum immunoglobulin, so maybe they have Waldenstrom's. Maybe they have some rouleau due to high protein. Maybe they've been exposed to medications. They have an infection. They're extremely sick. They can also have things like antiphospholipid antibody syndrome or lupus that, again, is associated with an increased antibody burden. But the risk of having a false positive DAT is much more common in a hospitalized population than in a healthy population. So there have been a lot of studies that have evaluated like how good is a DAT at diagnosing immune hemolytic anemias. And I will say its sensitivity, it's a pretty broad range, but its sensitivity is pretty fair, pretty good. So if your patient has immune hemolytic anemia, maybe 70 to 87% of the time you're gonna know that they have it and it will be positive. Specificity is not that great. So if someone does not have immune hemolytic anemia, your test will only be negative maybe about half the time. The positive predictive value is even unfortunately more poor. Only about 1 in 4 people who have positive DAT will actually have an immune hemolytic anemia. Its negative predictive value is much better. So 9 out of 10 people who test negative will not have an immune hemolytic anemia. So can an elution study help improve testing for warm autoimmune hemolytic anemia? Currently, there's no standardized practice to perform elution studies with every positive DAT. Every hospital has its own policy, whether or not they'll do it, so there's no overall standard that labs have to adhere to. For clinical hematologists, they might not even know their lab is doing the elution. They might not even know to look for these results. I know when I was training, I didn't know to look at these results and that they would be helpful in my diagnosis. So the role is really unclear, specifically because we know that so many people have a non-reactive eluate. And classically, it's been taught, oh, if your DAT is positive and your eluate is negative, you should suspect a drug-induced hemolytic anemia. But actually, cold agglutinin disease will also have a positive DAT and negative eluate, and that's just not emphasized in the literature. So there's no IgG to elute, so most of them you probably won't do an elution, but if you do, you won't find anything because there's no IgG, and that's what elutions are made for. And again, like I said, most clinicians don't even know we perform an eluate. So one of my research questions has been, what is the clinical utility of doing elution studies in patients with positive DATs and evidence of clinical hemolysis? If clinicians aren't even looking for it, why are we doing it? Is it actually adding to the diagnostic value of these patients? And then my secondary aim is, does a positive DAT and a negative elution always result in a diagnosis or workup of drug-induced hemolytic anemia? So what classic teaching is that, positive DAT, negative eluate, you think drug-induced. So are clinicians actually evaluating for that or are they getting to another diagnosis? So I did a single center retrospective review at my own institution of the positive DATs we had over a 3-year period, and I determined if the illusion was positive, negative, or not performed. And then I reviewed the patient's charts to see did the clinicians diagnose them with an immune hemolytic anemia, an immune hemolytic anemia meaning antibody-mediated hemolytic anemia. I then compared the LU pos group. So those where the LUet was positive, and then the patients who had a negative LUet to see what were the differences between these patients. They obviously were both diagnosed with hemolytic anemias, but was there a difference in reaction strength? Did one group, the LU pos group, have like more significant hemolytic hemolysis? So were there hemolytic markers such as hemoglobin, reticulocyte count, bilirubin significantly worse than those who had a negative LUet? And the diagnosis, was there a specific type of immune hemolytic anemia that was more likely to be diagnosed? And the treatment regimen I also evaluated in terms of how many different kinds of treatments did they get for their immune hemolytic anemia, specifically for worm and CAD. And then I also looked at just transfusion burden 28 days before and after the sample to understand the clinical severity of the disease. So, in terms of just DAT numbers in general, I identified 1,686 DATs were performed at our institution. DATs are a pretty common workup that we do for other things, such as transfusion reactions, cord blood DATs. And I excluded all of these because in this situation, the provider is not ordering it because they're suspecting hemolysis. It's really because of reflex workflow that we have in our blood bank. So I removed that and only looked at DATs that were ordered specifically by providers for concerns for immune-mediated hemolysis. There were within this group patients who had had multiple DATs drawn at different time points. So I removed the duplicates to account for 191 patients total who had a positive DAT. Of these, 36 patients had a positive LUIT, 132 had a negative LUIT, and then 23 patients I couldn't find any record that an elution study had ever been done. The clinical diagnosis of immune hemolytic anemia was 18. So 18 patients in the LU pos group were diagnosed with immune hemolytic anemia, 19 patients in the LU neg group, and then 3 patients in the no elution performed group. And here's just a little bit better view of that. So in overview is that 50% of the patients who had a positive LUIT were diagnosed with IHA, only 14% who had a negative LUIT, and 13% who did not even need a result to be diagnosed with IHA. Warm autoimmune hemolytic anemia was the most common diagnosis across the board, and it was 13 patients in the LU pos group, 6 in the LU neg group, and then 2 patients actually in the no LU performed group still had a diagnosis. And then cold agglutinin disease was much more common in the LU at negative group, similar to what we thought. And then in terms of the other different kinds of hemolytic anemias, I specifically looked at drug-induced, which was much more common in the LU at negative group, as we predicted, and then hemolytic transfusion reactions and passenger lymphocyte syndrome. So when I did my statistical analysis comparing the LU pos with the LU neg group, I noted that in terms of basic patient characteristics such as age, gender, race, there were no differences. I did find that the DAT strength was significantly stronger in the LU pos group, and essentially that means that the degree of agglutination was higher, so there was more antibody bound to the red cells in general. And that makes more sense because if you have more antibody bound to the red cell, when you do the elution, you're going to have more antibody in your eluate, and you're going to have a better test going into when you're testing it against your reagent red cells. So the LU-pos group had a polyspecific strength about 3 plus as the median, and then the LU-neg group was 2 plus, and then the LU-pos group had an IgG strength of 3 plus, and the LU-neg group was 1 plus, and there was no difference in complement. I also determined clinically was hemolysis different between the two groups based on clinical markers, and I did not see that there was any difference. So both groups seem to have the same degree of immune hemolytic anemias. And then I looked at what did the patients end up being diagnosed at. So IHA was much more common in the LU pos group. So if you had a positive DAT and a positive LUIT, you were 6 times more likely to be diagnosed with an immune hemolytic anemia. Um, and this is also positive for a warm autoimmune hemolytic anemia. So if you had a warm autoimmune hemolytic anemia where you had a positive DAT and a positive LUIT, you were again about 5.8 or 6 times more likely to be diagnosed with that. Cold agglutinin disease was overall more prevalent in the LUIT negative group. So 6 of those patients had that diagnosis versus only 1 in the LU pos group. Drug-induced hemolytic anemia was my secondary aim, and I looked to see were all patients in the LU-NEG group evaluated for drug-induced hemolytic anemia. However, not all of them were. Only a third of the patients in this group were diagnosed with drug-induced hemolytic anemia, and it wasn't that testing was sent. I really looked at did the clinicians mention it in their differential, and did they discontinue any drugs and determine that was the cause of the hemolysis. So it was not actually mentioned in the majority of the notes that there was concern for drug-induced hemolytic anemia for patients where it was and that the drug was discontinued and that ended up being the final diagnosis. It was about 30%. 30% of these patients had cold agglutinin disease, which again would present with a negative elution as we talked about previously. And about 30% actually still had a diagnosis of warm autoimmune hemolytic anemia despite not having a panagglutinin present on their elution. And then one patient had a hemolytic transfusion reaction. So then I looked at the sensitivity specificity of the elution in patients who already have a positive DAT. What does it add to the diagnostic value? And what I noted is that it does add specificity. At least in my study, the elution studies had a specificity of 86%. So that brought our diagnostic value to very good. And the positive predictive value was 53%. So that made it decent compared to where we were in terms of what the diagnostic value is if your elution DAT is positive alone. If your DAT and elution is positive together, then it's actually a little bit better predictor of whether you're going to have an immune hemolytic anemia. So if we put these together, we can really improve the way that we make these diagnoses in patients that have a strong suspicion for immune-mediated hemolysis. And I really want to emphasize that because, again, the positive predictive value is very poor. So if your patient does not have suspicion for immune-mediated hemolysis, you should not be ordering a DAT. You're going to end up with a positive result and not know how to manage it, how not know what it means for your patient. Really, it's only in those patients that have nuanced hemolysis you're thinking this is immune mediated, something that's happening, or based on their primary disease, they might have a secondary risk factor for having an autoimmune hemolytic anemia. For those patients is where this test makes the most sense. So my take-home points will be that elution studies can improve the diagnostic value of DAT testing for diagnosing immune hemolytic anemias by improving both the specificity a little bit and definitely improving the positive predictive value. There's no difference in the degree of hemolysis that we saw in patients who have a positive LUIT versus a negative LUIT, although the reaction strengths were significantly different. I think this is important to keep in mind that even if a patient has a negative LUIT, it does not mean that their disease is not as severe as someone who has a positive elution. And then the third take-home point is that not all patients who have a positive DAT with a negative elution will have a diagnosis of drug-induced hemolytic anemia. Um, Cold agglutinin disease should also be on your differential for these patients, and also you cannot fully exclude that they might have warm autoimmune hemolytic anemia despite the elution being negative. Perhaps the reaction strength was just very weak, but they still could have significant warm autoimmune hemolytic anemia that requires treatment. And these are some of my references. Thank you for your time. I appreciate it.